Afternoon. This is Dr. John Bennett from Miami, Florida. We have a show, Radiologist.tv, and today we have the honor of having Omer Awan MD, an assistant professor of radiology at the Geisel School of Medicine up in cold Hanover, New Hampshire, and we're also joined by Fike Sheikh, MD, a radiologist. First, I'll introduce Fike. Good day, Fike.
Hi, John. Happy to be here. I am very happy to announce that this is our first live show with Radiologist.tv, and we have Dr. Awan with us. A little bit about myself. I am a molecular imaging physician by training, and I'm currently an informatics fellow at UPMC. Dr. Awan?
Okay, very good. Welcome, Fike. We hope to have a lot more radiology TV shows, radiologist TV shows. And welcome, Omar.
Hi, John. Thank you so much for the lovely introduction. Hi, Fike, as well. My name, again, is Omer Awan. I'm an assistant professor of radiology at the Geisel School of Medicine at Dartmouth. I'm also the assistant program director for the radiology residency at Dartmouth. It's great to be here, and I look forward to doing this and many more shows with you guys.
Great, great. Okay, Omer, you can go into your presentation if you'd like.
Sure. Let me get into that. Let me know when you guys can see my presentation.
Beautiful. It's up there. Beautiful.
Yep.
Okay, so we'll go ahead and get started. So today we'll be talking about value-based healthcare for the radiologist. This is a very brief introductory type of lecture. Hopefully, you know, as time goes on, we'll dive into this concept a lot more. But, you know, as a preliminary talk, I just wanted to make this, you know, very basic and very brief, just to sort of introduce what we mean by value, what we mean for the radiologist, and that sort. Because, you know, in healthcare, you know, the term value gets thrown across all the time. It's not a topic that's new to anyone. Everyone is talking about quality metrics, value-based healthcare. So I thought, you know, just a brief introductory lecture would be great for all of us, and to see how we could use this from a practical standpoint as radiologists and how we can improve value. So we'll go ahead and get started here. But first, before we get started, I want you guys to meet Dr. Nancy Smith. Nancy Smith is a radiologist. She works at a busy national medical center. She's reading a lot of her volume is very high in reading CTs, MRIs, plain films, ultrasounds. She's pretty much reading every type of modality that's asked of her. She has to perform a various number of biopsies every day, 3 to 4. She gets interrupted multiple times throughout the day through phone calls, protocoling studies, talking to referring physicians, talking to patients, consulting patients. So she's practicing in an era where she's coming in extremely early. She's coming in, you know, her contract says that she's bound to work from 8 a.m. to 5 p.m., but, you know, more often than not, she's coming in at 7 a.m. She's leaving at 6:30 p.m. just to get her work done. So she's working in an era where, you know, the volumes are very high in radiology, and yet she's still asked to add value to her work. So how is it that she's, despite, you know, her workload and despite all of her responsibilities, she can add value in radiology? And that's kind of what we're going to be talking about today. So our learning objectives today are really just twofold. This is going to be a very basic lecture. We're going to, first and foremost, define value and value-based healthcare as it pertains to diagnostic radiology. That's going to be the first part of the lecture. And the second part of the lecture is going to be sort of elucidating the role of the radiologist in adding value. So how is it that we as radiologists can really add value in the things that we do, in the reports that we give, and sort of the actions and how we go about our practice. So first, we're going to define value and what that means for the radiologist. So the first thing that we have to understand about value is that value isn't really understood by us or through our eyes or through our lens. It's really understood through the eyes of the patient, and that's really a key concept here. It's a patient-centric model. So when we talk about value, we're talking about how are these outcomes perceived and how is the patient experience perceived through the patient. So when we dictate a report in diagnostic radiology, you know, we may be proud of the report, but if the patient's not proud of the report, then are we really adding value? Are we providing the information that's necessary for the patient and things that are pertinent for patient care? When we perform a biopsy, are we doing the things that are necessary to protect the patient? are we reducing complications that may harm or hinder the patient? So that's really what we're talking about when we talk about value. The other key concept is the equation that you see in red on the bottom part of the screen, where value is given as a ratio, essentially. Value equals outcomes or results over cost. So that's a key generic equation that one must understand when we deal with value. So you can notice that the numerator of the equation is outcomes and the denominator is cost. So obviously, because outcomes is in the numerator, value is directly proportional to outcomes. So if you increase results or increase the outcomes, you're increasing value. On the flip side of this is cost, which is on the denominator of this equation. So if you increase cost, you're decreasing value based on, from a radiological perspective. And if you decrease cost, you're obviously going to increase value. So that's a key concept as well. So knowing that, value is really outcomes or results over cost. Okay, and that cost is inversely related to value, and cost and outcomes and value are directly proportional to each other. So this is sort of a diagram talking about value in informatics and what we mean by informatics, value, data, and how they're all interconnected. So we as informaticists, we deliver value, we try to deliver value, we measure value, and we improve value. What do we mean by this? All of these things are interconnected. So by delivering value, what we mean is we're delivering value, and we're delivering evidence-based medicine. And what that means is that we're delivering medicine or guidelines that have been proven through outcome research, that have been published, and that have been proven through clinical trials, essentially. And we only, hopefully, provide that type of medicine, or that's the goal, to provide that type of medicine to our patients. And that's how we deliver value. So evidence-based medicine is crucial to the delivery of value, and that's what we mean by when we deliver value. We can give alerts and reminders through information systems and technology that we have in radiology to help us deliver the value, but ultimately we're going to be trying to deliver evidence-based medicine that have been established through practice-based guidelines. Measuring value is key, and that's also crucial for what we do. So we measure value through performance assessments of clinical, financial, and patient-reported outcomes. So just similarly as in finance, how we measure value through the budgets that we propose, through the return on investments that we have and that we've created, we measure value through clinical outcomes, clinically based outcomes. That means we measure through report turnaround times, and that means how long does it take for when the time an exam is completed, like for example a CT of the head is completed, to the time that the referring physician can actually see our report. So that's not necessarily the same time as after we dictate a report, a CT head, click sign, and then boom, that we're done. That's not necessarily the exact time, because a lot of radiology information systems, as you know, require a technologist or someone to finally complete the exam in the radiology information system before a referring physician can actually see the report. And a lot of dictation systems have a 5 or 10 minute lag as a quality metrics tool before a referring physician can actually see a report after the radiologist has signed the report. So turnaround time is one measure that we can do. Complication rates for biopsies is another clinical performance assessment outcome that we can measure. What is the rate of complications after a bone biopsy or after a lung biopsy? How many patients get pneumothoraces in our clinical practice after lung biopsies? Another metric or outcome that we can measure is something like what percentage of times do we report critical results in a timely fashion after 30 minutes within dictation? For example, what percentage of times do we report pulmonary embolism to the referring physician after we have diagnosed that on a CTA of the chest? So that's another value metrics that we can measure. And a lot of times we have reports and dashboards that can help us, with these metrics, if information systems technology or IT support have allowed us to create that in our practice as well. So that's how we measure value. The last part of this is improving value, and that's really that's crucial for practice quality improvement efforts, and for us to get better, essentially. And how do we improve value? Well, we have to perform data and perform research to do that, and particularly outcomes-based research to improve value. So if we're trying to figure out, are we doing a good job at notifying clinicians of critical results, the only way we can track that is if we actually measure that, and if we gather data on that. If we find out that the time lag is greater than our threshold. Let's say our threshold is 30 minutes within dictation, and we find that the average time is 2.5 hours. Well, then we use that data to help improve our ability to report critical results to our referring physicians. And we can do that through, as we said, outcomes research, root cause analysis, finding the cause to a particular problem, comparative effective analysis, comparing two different variables and seeing which one is better and which one is more effective clinically. So those are ways that we improve value. So this chain that you see, deliver value, measure value, and improve value, this is integral for the whole process of quality improvement. This is essentially the chain or the circle that we describe when we talk about quality improvement and practice quality improvement, which is very integral to the practice of radiology and has been a major requirement for the American Board of Radiology in terms of recertification, maintenance certification, and milestones for diagnostic radiology residency programs all across the United States. Those are integral concepts for value and practice quality improvement. So now that we've defined value and value-based healthcare as it pertains to radiology, we want to talk about what's the role of the radiologist in adding value? How is it that a busy radiologist who is continuously being asked to do more and more on a daily basis, how can they essentially add value? Well, we essentially come back to our equation, right? We come back to value, and value equals outcomes over cost. So the way a radiologist can add value is you improve your outcomes, or you improve your numerator, or you decrease your denominator, you decrease costs. And that's really the heart of how we, as radiologists, can improve value. And we can improve outcomes of the numerator of this equation by a couple things. This is just a very preliminary list of how we can do it, but we'll talk about these hand in hand. So communicating to referring physicians. Communication is key for radiologists. A lot of times, we have a stereotype where a radiologist just sits in a dark room, just dictates studies, and doesn't talk to anyone, and that's it. Well, that paradigm has completely shifted, and that paradigm no longer exists because radiologists are being asked more and more to really talk to patients, talk to their referring physicians, communicate critical results to their patients, and that gets done on a daily basis now in academic centers and in private practice centers all across the world. An easy way to look at this is if you make a diagnosis of a head stroke or a tension pneumothorax, what good is that finding if we haven't communicated that to our referring physician so that they can act on that, and if there's a tension pneumothorax, put in an emergent chest tube. So really communication is key, and doing that in a timely fashion is what's going to drive patient-centered outcomes where there will make a difference for the patient and patient care, essentially. So communication, again, is key. Decreasing turnaround time is another outcome that we can hope to improve. So the time it takes between when the exam is ready for us to read in PACS to the time that the referring physician can actually see our report. Obviously, we want to decrease turnaround times so we can have the results ready so that the physician can act upon our results based on what we say in our report. So obviously, the lower the turnaround times, the better, and more efficiency as radiologists, and also more improvement in patient outcomes for when treatment or emergent intervention can be performed for studies that we read. The third way we can improve outcomes is being more clinically accurate. And that's tough, especially in a time where, as we mentioned in our index physician, Dr. Nancy, at the beginning of this talk, where there's increased volumes. I mean, radiologists all over the world are asked to read more studies every day for the same amount of pay, or in fact, sometimes decreased amount of pay. So, and we have to be, we're reading more studies, everyone's going faster, but we still have to maintain our clinical accuracy and be totally accurate when we read our studies and not miss crucial and critical findings. And the way we can do that is a lot of institutions have instituted a peer review system whereby, radiologists are, blindly looking at other radiologists' reports and seeing if they agree or disagree with those reports. And it's a way to give feedback to a radiologist, in a very non-confrontational way, for the purpose of improvement, for the purpose of improving the way we read studies. And we do that here at Dartmouth Hitchcock, where we do the ACR rad peer system, where every month we're asked to look at 5 studies of reports that other people have read, other staff radiologists have read, and see whether we agree with them, disagree with them, whether it would be a clinically significant miss, clinically insignificant miss, and that gets tracked, and that becomes part of our record, where we meet with the chairman every 6 months to talk about how our performance has done compared to other radiologists as well. So peer review is a great way to improve clinical accuracy in a very non-confrontational way. The other way to improve outcomes is to perform outcomes-based research, to really go ahead and find a problem or find an issue in radiology and perform research on it, see if there's any difference in outcomes based on different variables or whatever you're trying to test. So those are just 4 easy, practical ways to sort of improve outcome and to add value as a radiologist. The other way we can add value as a radiologist is to reduce costs, and that may sound hard to do as a radiologist because we're not really at the forefront of ordering studies, and we're not really at the forefront of chart or of medical billing, where we're actually putting the price or putting the charge on certain studies that we read. But there is a practical way we can reduce costs, and that is in the way we protocol studies. So studies get ordered all the time. We as radiologists are the gatekeepers for studies, and we decide what studies should be done and should not be done. We decide whether contrast should be administered for a study or contrast should not be administered. So we're definitely the gatekeepers for radiology. So we have the autonomy or the authority to decide what study actually gets performed. And we have to ask ourselves every time a study is given to us, is this the best study that's necessary? Is contrast necessary? Do we need to radiate this pediatric patient? These are questions that we always have to ask before we actually perform a study. And is a study justified based on ACR appropriateness criteria? The ACR, the American College of Radiology, has published guidelines based on what studies should be performed for certain clinical indications. So a patient is coming in for altered level of awareness. Is a CT head without contrast appropriate for that indication? And the answer for that situation is yes, of course it is, to rule out a stroke. But that's some way we can, sometimes unnecessary studies get ordered, and we can be the gatekeepers and prevent studies from being done, and that can reduce costs, and that can certainly add value following the ACR appropriateness criteria guidelines. So that's another practical way we can add value as a radiologist. So in summary, what we've done here today is we've defined value and value-based healthcare as it pertains to diagnostic radiology. And value, as you remember, is a simple equation with outcomes or results in the numerator and costs in the denominator. So obviously, if we increase outcomes, we increase value. If we increase costs, we decrease value. If we decrease costs, we increase value. And we talked about the role of the radiologist in adding value in terms of improving outcomes and reducing costs by communicating more effectively, decreasing turnaround time, using rad peer and increasing clinical accuracy, and things of that nature. And then we talked about reducing costs by protocoling studies appropriately and using the ACR appropriateness criteria for reducing costs and hopefully improving value. So again, this was a very short presentation. Thank you so much for tuning in on Radiologist TV. We really appreciate you listening to this. Feel free to email me with any questions regarding this talk. My email is right there listed, omer.a.awan@hitchcock.org. I look forward to your questions, and thank you so much for everything.
Very good, Omer. That was really nice at the end that you give your email address. That's excellent. Well, Fike, I'll defer to you because you're a radiologist and you have some experience in informatics. So why don't you start off with the questioning?
Yeah, Dr. Awan, thanks again for the excellent talk. I did want to bring up 2 points here. First one is that you mentioned that how one of the aspects of value assessment for a radiologist is how the patient consumes the report. We are in an era where patients do have access to our reports, and whether we like that or not. And so the first part of my question is that what are your thoughts on whether that's good practice or not, and if it leads to any kind of improvement anywhere? And second part of the question is that accepting that it's there, there's this whole movement about being, if you will, politically correct in our reports and not use harsh words or things that we otherwise would feel necessary to use, words that we use to convey our concerns if we have any, straight to the ordering doctor. What are your thoughts on that?
That's a great question, Fike. First and foremost, let me start off by saying that I think that it's great that patients have access to their reports. I think that patient autonomy is important in this era where patients are asking more questions. They're surfing the internet to find out more about certain diagnoses. They're coming in much more well educated than we've seen in the past. I think that patients are certainly entitled to have their reports because this is part of their healthcare, and they're playing more of an active role in their healthcare. And there have been numerous avenues for patients to get more access to their reports. There's something called the RSNA Image Share Project, whereby patients are getting full access to the reports by taking their images. Hospitals are putting images through a cloud, and patients have like an RSNA token ID whereby they're able to access those images and things like that, and they're able to share those images with their referring physicians. So I think that it's great that they have that access, and I think that that they're morally entitled to have access to their images because those are their images. Though it's part of their healthcare. So that raises a lot of questions. I understand, but I think that in itself is great. In terms of the second part of your question, I think that's a tricky question because now that patients do have access to their images, vocabulary is sometimes altered because clinicians and radiologists know that they have to that their patients are reading the reports. But I think that it's important to be completely honest. You know what I mean? A lot of times for example, this is a very basic example, but we say if there's an abdominal X-ray that's underpenetrated, overpenetrated because a patient happens to be obese, a lot of times we say examination is limited secondary to the patient's large body apparatus. I still say that, even though that may be an offensive statement to the patient. I mean, I'm not saying that the patient is obese, but I am saying that, my interpretation is going to be somewhat limited because of the patient's large body apparatus, because they're able to absorb some of the X-ray beams. So I think that is important to be honest and make those limitations known, because that shouldn't hinder your interpretation of the report. Because I think ultimately, if you leave those type of points out, then you're actually doing a disservice to the patient. So again, it's always about patient-centric care and to give the best service that we can to our patients. And I think that honesty is crucial for that.
Yes. Now, one of the reservations that I have, I guess, about this whole thing is that in order to be, when we are made to be aware of the fact, which in principle is a good thing, what ends up happening is that we may have to sort of notch down the semantics a little bit, which otherwise we would be very vocal about. For example, if there's a glaring finding that, based on a cancer imaging study, that I would want to be very, very, I want to emphatically express it so that and convey it to the ordering doctor so he acts upon it in a more direct fashion, in a more in a more expedient manner. But if we are too worried about how it is being perceived by the patient, I mean, do you feel that there is a concern that might actually hinder delivery of information?
I think it will. Yeah, it will hinder delivery of information if one is not completely honest. So I think that you should be adamant about your findings, because that's going to ultimately affect patient care. Remember, we're also the guard keepers for the patient. So if there has been marked interval increase in the size of a mass, you have to report that. You know what I mean? Because that's going to affect the patient care. That's going to affect the way the clinician is going to view that report and to act on that report based on upping chemotherapy or whatever it is that they want to do. So I think that patient perception in terms of value is based really on their delivery of care, and I think that dishonesty is going to decrease value because it's going to negatively affect their perception of care, whereas honesty is going to allow the right care to be done at the right time in the long run, and it will affect their care in a positive manner. So I think part of it is divorcing feelings from or emotion from reality, essentially, or from emotion from, what being objective in reporting clinical findings. And I think that, a radiologist should really be objective in reporting clinical findings, regardless of how the patient may feel about it. Does that make sense?
Right. Yeah, I agree. But there is actually now a movement, at least in the industry side, where they're thinking about coming out with two reports, actually adding more work for us. One like an abridged version for patient consumption, and the other one for the ordering doctor. I don't necessarily think that's a good idea, and I hope that doesn't go through. But and also I think that at the end of the day, sometimes, for example, when a whole workup is being done, there are, tumor markers being ordered to labs, and then there are imaging studies, and there are biopsies and stuff like that. And at the end of the day, when everything is available to the ordering physician, he will decide what stuff to act on and what not to act on, and he will have post-test likelihoods and all of that stuff. So a radiology report may be screaming at him about something, but then he would have a larger, sort of a more holistic idea of the whole thing, and would act on it, based on a lot more information that we would ever know, because we are just imaging is one snapshot of what's going on at that time. So that's why I think the ordering doctor is the one that actually sort of brings me to my next question too, about radiology consults. Now, I clearly understand there's a role for that in nuclear therapeutics, there's a role for that in interventional radiology, maybe even ultrasonography, but being a staging breast cancer, CT, should you be really, should the patient come to you and ask questions about the images, when really your report should go to the ordering physician, and he will take other things into account and then give a more balanced or more useful answer to that question?
Yeah, that's an age-old question, Fake, and it's a debatable question as to how much we should really be communicating with our patients, and to what extent we should, and you gave that example of a staging CT for a breast. I think it depends on how comfortable each individual radiologist is, to be honest with you. I mean, some people are very comfortable, delivering certain type of news and being able to communicate with their patients directly. Others leave it towards the referring physician. I'm not sure I have a great answer for you, but I will say that I used to be on call when I was a resident at the University of Maryland, and we had to do ultrasounds while we were on call in the middle of the night, and there were times when I would be doing an ultrasound on a female patient who was pregnant, and it was a failed pregnancy. I mean, I was pretty much scanning a failed pregnancy, and the dilemma comes: are you obligated to tell the patient that it's a failed pregnancy, or do you let the clinician tell the patient that it's a failed pregnancy? And that's a tough decision, because on the one hand, exactly what the findings are, but on the other hand, the referring clinician knows the patient much better, knows the patient's history much better, and has been traditionally been the person to totally communicate those findings with the patient. So I'm not sure if there's any right or wrong answer, but I do believe that, as I'm doing the ultrasound in the middle of the night, because I'm seeing something, I'm morally obligated to tell that patient, hey, this is an abnormal study, or this is an abnormal test, because I can, while the clinician may know the patient better and the patient's clinical, the whole clinical story better, I know the imaging part of the patient's history better. So because I'm interpreting this part of the study, I feel obligated to tell the patient that this is a failed pregnancy. So the same may apply in your situation when you're talking about, staging CT breast. So I think it ultimately boils down to how comfortable a particular radiologist is in delivering, sort of news and information. But I don't think there's any right or wrong answer to that.
Yes, well, these were very, very helpful answers. I appreciate your perspective. I just hope that we're not entering in a phase where we are mandated to report things that otherwise would be left best for the ordering physician to do. And the regulations are creeping into pretty much everything that we are doing. But that's, I guess, that's another talk for another day.
Sure.
But thanks again for a great talk and for this discussion, John.
Yeah, I'd just like to ask a couple of questions. One of them, is that, communications improved so much now, and I'm sure Mike will agree. And I know as an ex-ER doc, I constantly had questions in my mind. Am I ordering the right test? Am I ordering the right test? And I think if I was working today in the ER, I would text the radiologist and say, we have a patient suffered inversion injury. Can we get it? I don't know if you do tomograms. Those are the old days. But do you communicate with doctors by text? How do you, or do they come to the radiology suite to say, hey, what should I do? What test should I order? Or do you text things or communicate by smartphones? Or what kind of, how do you talk to doctors that way about clinical situations and the best test to order?
Yeah, that's an interesting question, John. Thanks for that question. So I'm an ED trauma radiologist as well as a musculoskeletal radiologist, so I actually do work overnight at Dartmouth, and I interact with the ED physicians all the time. And, we text sometimes. I mean, it's very rare that we text. When I was at the Beth Israel Deaconess as a musculoskeletal radiology fellow, we actually texted a lot, and we used email a lot. But at Dartmouth, at Hitchcock, we don't really text as much as, they usually just pick up the phone and call me, or they'll actually just come to the reading room because we're located literally right across from the emergency room. So it's literally a 15-second walk for them to come over and talk to me and ask me, is this the most appropriate study to order? So in our case, it's literally a walk over to us or a phone call. But certainly at other institutions and other practices, it could definitely be text. It could definitely be emails. If it's a non-urgent study that can wait till the next day, I think email is an appropriate avenue to ask those questions, as long as obviously patient information is encrypted and HIPAA compliant and things like that. But I agree with you. I think that now that with the advent of social media and all these different avenues for communication, it's opened up a whole new way of communicating and asking questions.
Yeah, I would think it'd be more effective. So. Well, I'd like to thank you, Omer, for coming out, and I hope you do many more. And thank you, Fight, for getting Omer. And we'll continue on when we get another speaker.
All right.
So good night, everybody. And hang on, guys. We'll chat.